Welcome everyone. Welcome everyone to the Columbia Justice Lab series on research and justice policy. In this speaker series, we're exploring the relationship between research and policy, and we ask each of our speakers to address the theme of how research can help make the public policy response to crime more effective in contributing to communities safer, can make the public policy response to crime fairer and radically less punitive. We're grateful for the support of Columbia's faculty for arts and science, and to former Columbia Dean Fred Harris for making this series possible. I have a couple of notes on our format. This is a Zoom webinar, so audience members are muted with their videos off. We're reserving time at the end of the hour to respond to audience questions. If you're on Zoom, use the Q&A feature to pose questions at any time throughout the discussion. Our online moderator, Sam, will select questions for Emily to address after this presentation. Sam, do you want to introduce yourself?
Hi, everyone. I'm Sam Plummer. As Bruce mentioned, please submit any questions you have using the Q&A function at any point during the presentation. And if you want your name and title, also happy to include that in the Q&A. Thanks.
Great. And if you have any technical questions at all, feel free to put them in the Q&A as well. So today, it is a real pleasure to introduce Professor Emily Wang, professor at the Yale School of Medicine, where she also directs the SEICHE Center for Health and Justice. Emily leads the center's research program, the Health Justice Lab, which receives NIH funding to study how incarceration influences chronic health conditions, including cardiovascular disease, cancer, and opioid use disorder. I was really, really excited when Emily accepted our invitation to be part of this conversation about how research can have an impact. Emily has made so many pioneering contributions to this project in so many innovative ways. She's the co-founder of the Transitions Clinic Network that emphasizes primary care in partnership with formerly incarcerated people as just essential to the reentry process. I had the pleasure of working with Emily on the National Academy's expert panel on COVID in prisons that we took on at the height of the pandemic. A lot of her research takes a participatory action approach, which she'll talk about today, and this involves actively collaborating, conceptualizing, and executing work with directly impacted communities. She's also a participant and great friend of the Square One Project. There is literally not enough time to list her many accolades. Suffice to say that Emily is a MacArthur Fellow. Her work has been extensively supported by NIH, and she's published very widely, including in the Lancet, JAMA, and the American Journal of Public Health. And in our many communications, one of the favorite threads I have is discussing our respective multiple children, twins and triplets we have going on our text thread. So with that, I will turn it over to Emily. And Emily, what I'm thinking is I'll go off video now, but at the end I'll come back on video, and we can be in conversation if that works. How does that sound?
That sounds great to me. And, you know, it's a real pleasure to be here. I was thinking that it would be more of a conversation where we'd be chatting back and forth, but we're going to roll with this. And it's a real honor to be in conversation with the Justice Lab, with you, Bruce, Sam, and the audience here. So for the next 40 or so minutes. Let me just get my screen. Uh-oh. I wanted to share. Thank you for coming back on.
How can I help?
I'm not sure. I should have shared my slides with you all. I see it here and then now I cannot share my screen.
You've got the share screen button?
I do.
Okay.
Maybe, should I leave and come back on? I'm sorry about this.
Uh,
I'll just excuse myself to the participants, which is saying I'm on the wards these last 2 weeks. And so I also can send them to you right now. That sounds great.
yeah.
There's too many pictures for me to share. Let me just try to go on and off. Yeah, sorry about this. I think that's the best solution. I'll be right back.
While we're waiting for Emily, I can announce our final talk, which will be on April the 8th at noon. So next month, we're going to hear from Andy Papachristos. Andy is a professor of sociology and faculty fellow at Northwestern's Institute for Policy Research. And he directs really a terrific center at Northwestern called Corners that is focusing on community-based responses to gun violence. And Andy will be joining us. Andy will be joining us next month. Like a few of our speakers, Andy, Emily, and Tracy, in different ways, have been leading centers that are all exploring this question of how can research make a difference in the policy process. I think not just in incremental ways, but in ways that might be really transformative. And Emily is back, I hope. Hey.
Hi. Back again, and I think I did it.
Brilliant.
We good?
Looks good.
Great. Sorry about that. Okay. So, we are at the 50th anniversary of mass incarceration. And for too long, our primary policy solutions have been ones which I feel are devoid of a critical component, and perhaps the most important component of sustained reform, namely the input of people that have been disproportionately incarcerated in the last 50 years. And so a primary goal of mine is to create the systems to include their perspectives, values, and deep expertise in the policies and practices and institutions that are specifically focused on health and well-being. And I've done so by applying community-based participatory research in this approach as a strategy for mitigating the harms of mass incarceration. And I start the afternoon, our conversation together, with this photo. It's one of my favorite. It's the first cohort of Transitions Clinic Network community health workers almost a decade ago, as a reminder that they are our biggest asset to our science, to our health system transformation, and the institutions desperately need and change. Oftentimes I get, kind of the response like, this must feel good, or it's like the nice thing to do. But it's really their expertise that actually makes our science more accurate, more scientifically rigorous, our work more honest and urgent, and it makes us more capable, our team, to identify new approaches to solve these complex issues. And so today I wanted to start by defining what I mean by community-based participatory research, to talk explicitly about the health risks of incarceration, and specifically, and I know that this is not news to some of you here, but really drill in on the healthcare systems in carceral facilities and post-release. Provide, if time permits, we started late, but 2 examples of where we've used CBPR and how they've improved science, health, and even changed institutional cultures, and then end with some concluding thoughts. So the definition of CBPR I frequently turn to, and again, there's a long tradition of participatory research, and it emerges in different fields within health services and health sciences. Often the ones that we anchor ourselves around is one provided by Barbara Israel. CBPR is a partnership approach to research that equitably involves community members, organizational representatives, and researchers in all aspects of the research process, in which all partners contribute to expertise and share in decision-making and ownership. And that's the core part. It's a really kind of an issue of governance, ownership, and power. So CBPR, often it's talked about, is kind of a method, and it isn't. It's a real orientation to the research that fundamentally changes the roles of a researcher. And it's an applied approach. And the goal of it is to influence change in community health systems, programs, and policies, and explicitly works to invert normative power structures. And increasingly, I think in the health sciences, I've certainly seen this through my career, there's been more and more focused on community engaged research, and that's kind of the large umbrella, and it really ranges. So, a lot of work that I see is really community placed, and then increasingly, community-based participatory research is at the other end. And community placed, the emphasis still is on the researcher's goals. There's a community organization involved, perhaps in some component of it, or a very little component, but there's involvement, and an academic product is the key endpoint. You're trying to get at a scientific question, you're partnered, but it's really kind of focused on what your issues are as a researcher, whereas CBPR is really focused on the community goals. It's focused on capacity building. A researcher is just a vehicle for action. Sometimes it's a vehicle for capacity building. Sometimes it's a vehicle for even thinking about how it is that you can increase the budget of a community organization. There's high engagement for both, and a manuscript is truly secondary. And so where I wanted to go is to focus in on health and healthcare, and especially to illustrate how off the power structures are within medicine, especially for those that are justice involved, to kind of illustrate to you all why it is that CBPR approach is a good approach to research in this population. And I know that this probably isn't news to some of you, but perhaps it is news to those of you that haven't practiced medicine but time the carceral system or post-release. Bruce didn't mention this, but I'm a primary care provider by training. And so a lot of my lens is also really focused on how is it that we can both unroot the power structures that exist within medicine through research and change policy in that way. And so these pictures all come from within San Quentin Prison in California, where I had a longitudinal primary care practice as a resident. So definitely more than a decade ago. And these permissions are shared, these photos are being shared with permission from the Department of Corrections in California and from these patients. And I'm showing this to illuminate, for those of you that haven't stepped behind bars before, what the provision of healthcare might be. After 50 years of mass incarceration, what we're seeing is the aging of a whole population of individuals behind bars. And we can get the impression that actually those that are incarcerated are healthy and young. And the reality of it is that about 85% of individuals who are incarcerated have a chronic medical condition that warrants longitudinal primary care. And of course, like this gentleman right here who has COPD and asthma, this includes physical health conditions, diabetes, hypertension. It includes infectious diseases like hepatitis C, substance use disorders, and mental health disorders. And you know what I'll note here is that you can see they're just waiting to see the doctor. This is a regular day. This guy's getting a nebulizer treatment. You can see this gentleman right there waiting to see the doctor, held in a cage. And this is the experience of healthcare. What drew me to this as a younger internist and kind of blew my mind at the time is that healthcare is constitutionally guaranteed in carceral facilities. And it's such that this population of individuals, about 40% of individuals are newly diagnosed with a chronic health condition while they're incarcerated, many of whom are first engaging with healthcare as an adult behind bars. But just because it's constitutionally guaranteed, of course, access is limited by all sorts of institutional policies. This here is pink slip. It's a kite that patients have to fill out when they want to see a doctor. And this is a clinic actually for individuals that have HIV disease. So again, there's no confidentiality. The correctional officer is just walking by. And this kite you have to fill out when you want to see a physician. And at the time, this of course is not happening in California now, but it certainly happens. So think about the kind of power dynamics at play here. You have a health request, you need to see a doctor, you have a symptom. The kite's first evaluated by a correctional officer. If the correctional officer thinks that it warrants medical attention, it goes to a nurse, and then at the time then goes to the physician. And so again, while there's a constitutional guarantee to care, there isn't access the way that we imagine it in the community. Secondly, in many places, access to care is limited by having a co-payment. In Connecticut, where I live, it's $3 to see the physician. And you know, $3 doesn't sound like a lot, but for those who are incarcerated, that's equivalent, if you're lucky enough to have a job, that's equivalent to 4 days of pay. And so you make 75 cents a day, and you have to save 4 days of pay to see a physician. And so there's all sorts of policies that exist that create different access to care behind bars. Now, this photo comes from the daily rounds of a patient who is just diagnosed with hypertension, and he's getting his blood pressure checked. He's just been discharged from the hospital with hypertensive emergency. So when your blood pressure gets sky high, you get in the hospital and then come back. And you can see we're rounding on the patient. And again, just notice the setting in which healthcare is being provided. This isn't a clinic. We threw the blood pressure cuff through the hole and the guy's strapping it on. And of course, for those of you that have ever had your blood pressure measured, you know that this isn't the way to check it. There's no confidentiality in discussing medications. You know, what's notable here too is that this gentleman every day at the crack of dawn would be woken up by a correctional officer. He's led over to the infirmary where the nurse provides him medications. She gives him his new, blood pressure medications, amlodipine, lisinopril. He would take it, a cup of water. The nurse checks to see if he's cheeked it. And, there's no reason why he'd cheek it. But again, this is how you're monitored and how you're surveilled. He swallows it and goes back to his cell. And so while adherence to these medications is almost 100%, it's an incredibly passive system of care, almost infantilizing individuals. And if you refuse it, And we've had certain patients, and then some studies that we've done also. For instance, if you refuse to take your insulin, you can often be punished and sent to administrative segregation. And so there's this real tension with the administration of chronic medical conditions that's really unique to the carceral system, making self-management very difficult. Individuals that have been incarcerated never drop their own insulin, rarely keep their medications on self. And so what the expectations of healthcare behind bars is totally different than what it is when people come home. And then, of course, there's lots of attention about this in the press. The quality of care is quite variable in our nation's 6,000 carceral facilities, and it varies by facility to facility. This is a picture of a gentleman taking methadone for treatment of his opioid use disorder. Again, there's 3 FDA-approved medications for the treatment of opioid use disorder that reduce death, mortality from overdose, but also reduce return to carceral facilities. And yet the majority of carceral facilities do not provide all 3 of these FDA medications. In fact, there's no governing body that oversees the quality of care in our nation's carceral facilities, unlike for the community health system of hospitals. So we have systems of monitoring if you're meeting the basic kind of minimal standards for quality of care, and this just doesn't exist. And so for chronic conditions, opioid use disorder, diabetes, the decisions that are made about what medications are delivered, what the protocols of care are really variable and are not overseen by any standardized body. And then I always want to show this photo just to indicate that really the conditions of confinement impact disease management incredibly, and in ways that I think for those of you that haven't gone behind bars, it's almost hard to imagine. This is a photo of a patient with COPD, much like the guy that I started the talk with, who's oxygen dependent, was held in administrative segregation and solitary confinement and required oxygen. And you would hear him bamming on the door every time that the tubing kinked and he could no longer breathe. And the rationale, of course, is that the tank was being held outside of his cell because it would be a danger to have it inside. And so what's really clear, what's really evident from this photo is how health is totally and completely secondary to safety, control, and punishment. And, I think often about kind of how this person must have felt, seeing physicians, nurses, healthcare staff walk by this, looking at this daily and not doing a thing. That our healthcare system is truly complicit in these health harming behaviors. And so it's no wonder that patients that have been incarcerated might be distrustful of these health systems. How could you possibly not if the system's treating you this way? And so, to my colleagues that are practice outside, often you're like, well, that's healthcare behind bars. And I think that the point has been made again over decades, 50 years of this, is that almost everyone comes home, leaves this healthcare system behind bars and returns into the healthcare system in the community. And so what happens when people come home in terms of their health? Well, many correctional facilities do not have a systemized discharge planning process. So, the mean time inside is at least more than 2 years. Most have seen a physician. And yet people will be released back into the community without their own records, not knowing, not having a primary care appointment, having a short supply of medications. And again, now newly, again, with these chronic health conditions that have been diagnosed in the community, having to navigate the healthcare system behind bars. What's more is they come back, of course, without insurance. They may have had Medicaid before, and now they have to activate it and face significant barriers, as I'm sure y'all have discussed here before, in meeting their basic needs. So hard to find a job, can't get a housing, hard to even kind of find food. And large studies from the United States in multiple different states have shown high risks of hospitalizations and death in the weeks, in months and even lasting through a year following release from a carceral facility. And so again, what is it? How is it that as a health system, we can navigate these significant health harms? And, I pause here to say this, is that I wanted to make the point is that when they come home, I think our community health system is equally brutal. We have been taking a hard look at how our community health system takes care of individuals post-release. And here I paint a picture or share a photo of a patient who is shackled again while getting chemotherapy. And so this is not just an issue of how we've criminalized and dehumanized a certain subset of populations when they're behind bars, but it continues when they're in our community health systems. And so a real question through my career is, how do we undo this harm? How do we start creating trust in communities that have lots of reasons to feel like our health system is not worthy of that trust? And how can CBPR be a path by which an approach by which we undo that harm? And so I'll shift to an example. During residency, and so it's almost, not quite, but definitely more than a decade ago, I became obsessed with this transition of care, of people released from the carceral facility, coming back home into our health system, and wanted to at least mitigate this increased harm of death and hospitalizations post-release. I trained at UCSF in San Francisco, where there's a long tradition, rich expertise of formerly incarcerated, currently incarcerated leaders that have been fighting for the resumption of, or not, they've never had the rights, but civil rights of individuals with criminal records, including all of us or none, and legal services for prisoners with children. And met with leaders in that community to talk about what I thought was a pretty easy issue at the time, the transitions in care. And what we did was convened many focus groups of people that had been incarcerated, healthcare leaders that had criminal records. We went inside but San Quentin to talk about kind of, again, trying to identify what are the core components that they wanted to see in a program that would address their critical health needs immediately post-release. And based on these conversations, based on partnerships with formerly incarcerated individuals, designed the Transitions Clinic program. At the core of this program, and here's a picture of my colleague, Lisa Puglisi, who's a physician who leads our Connecticut network, my dear friend and colleague, Jerry Smart, who passed away, but was a community health worker and one of our patients. And at the core of this program, what we wanted to do is shift the paradigm of care. So instead of this individual coming home facing inordinate barriers to meeting his basic needs, but also kind of not knowing how to bridge his own health care. The first person that he would see is a community health worker. This is Juanita Alvarado, ideally. She's met him while he was incarcerated prior to release, talk through kind of what his priorities are, what his healthcare needs are. And it's the first contact. He's there available, she's there available immediately, sometimes hours post-release to help him navigate the healthcare system, the social service system, to be social support right post-release. Within 2 weeks, they would see a healthcare provider that had known that he'd been incarcerated, welcomed him home, understood that there was a whole healthcare system behind bars. Most individuals who practice medicine don't actually know that there is even a system behind bars, would address both the acute needs and then slowly over time develop a plan to meet his healthcare needs, his health needs, but also to think about the ways that the health system can keep him home and safe. And then lastly, would attend to their social determinants of health, is what we call it, our social needs that are related to health, food, housing, employment, and really be able to navigate this healthcare system. And in establishing this, again, almost 15 years ago, we knew that we wanted to study the program. And so wanted to use this CBPR approach and convened a community advisory board that included those who were incarcerated, but also individuals who held the power, who could create programs, who understood the policies that existed in San Francisco, legislators, leaders of health systems, the DA, the public defenders, and formerly incarcerated individuals, and convene them around the table to talk explicitly about how it is that we should study this program. And of course, used a CBPR approach. This was led at that time by Ron Sanders, a community health worker who was the first in transitions clinic, and talked very openly about how best to study this. There's all sorts of study designs that are available to us, ones that are, I think, more rigorous than others, and felt that it was important to have the most rigorous science available to study interventions that are for the most marginalized, and agreed upon conducting a randomized controlled trial. And you can imagine that the conversations then were about, well, is that ethical? The program had been going on for at least a year and a half. People felt like, well, there's no service before, so if you randomize individuals to get transitions or nothing at all, that was horribly unethical. And so as a group, and we had long conversations about this, you wouldn't imagine that, you know, this group would be that interested in the design of a randomized trial, but this is where we were at, discussed this and agreed that the appropriate comparator was that everyone would get the 2-week transition visit, and then they would be randomly assigned to either transitions clinic program or expedited primary care. We knew that it would bias our study towards the null. So all the policymakers also understood that if we had a negative study, it didn't mean that there wasn't benefit of transitions clinic. And then for ease, we agreed that 12-month data, 12-month administrative data from our electronic health record in county jail would be the most efficient way to capture outcomes of healthcare utilization and return to jail. And these were not the outcomes that I care about, frankly, or that my patients or community health workers care about. But these are the outcomes that health system administrators, city officials really cared about, recognizing that if our core value was trying to study the benefit of transitions clinic so that it might be sustained, that we anchored ourselves around these outcomes. And so this is what I mean by really having kind of input throughout the process from formerly incarcerated individuals on balance with researchers and policymakers about how best to design this study. We studied it. It was a small study of 200 individuals. Again, everyone got a 2-week visit. And what we found was at the end that individuals did engage in care, and there was a 98% participation rate in the study. And at the end of 12 months, those that were randomized to transitions had about 50% fewer emergency department visits in the 12 months following a prison release, and no differences in return to jail. And so ultimately, what we've been able to do with this and other studies, and this is just one example of where we've used a CBPR approach and we've used it in other studies. Now the program has grown to 48 programs in 14 states. Around the country, we've provided care to more than 10,000 patients and really have studied, again, different sorts of outcomes, including a study in Connecticut where we found where we had better ascertainment of criminal justice outcomes because it's a unified system, so we could look at jail and prison, and we could look at parole, probation, arrests, that the program, when studied in Connecticut, reduced return to prison by reducing parole and probation violations. We've worked in many of these states with policymakers and community health systems to implement the TCN model. And in so doing, over the years, you know, we've been at it for 15 years, have tried to create tools to better engage formerly incarcerated individuals in the research. So this is a grant that I got through PCORI, the Patient-Centered Outcomes Research Institute, where we convened community health workers, patients with histories of incarceration, with correctional or health system leaders, here's Colin Gallagher from the Connecticut Department of Corrections, to collectively use data that we collect in the network to then design their own studies and create hypotheses. We built this platform that would share the data in real time. And, you know, we've tried to iterate on this over and over so that participants in the study could actually see their study in real time, understand their health in relation, and then start thinking about how it is what studies ought to come next. And, I'm happy to talk a little bit more about this, but this has been plus or minus. But this is a real core part of it, of CBPR, which is that the analysis part is always a little bit more challenging for community leaders and those who've been incarcerated to engage in. And so we've been trying to deploy informatics tools to better engage individuals in the analysis. Currently, as the network has grown, we now have a randomized controlled trial. I won't spend, I realize I'm running out of time, too much time in it, but we have a randomized controlled trial looking at opioid use disorder treatment cascade. And so this network that's born out of practice has now been a platform to study key critical issues that are real sources of morbidity, mortality in the population. Sometimes the questions are driven by patients, community health workers themselves, and other times they aren't. And we're pretty deliberate about trying to figure out when and how to do so. But one of the things that I will just say here is that because we've been engaged so honestly with people that have a history of incarceration within the Transitions Clinic Network, many of our leaders are those that have been incarcerated, have been at the table for many policy discussions. We've been deliberate about trying to think about the data that moves this work forward. And so with CMS's recent announcement for the 1115 reentry Medicaid waivers, the Transitions Clinic Network was the only model that's indicated for really trying to bridge care prior to release, 90 days prior to release, back into the community. And I think that this speaks a lot to the leadership within TCN, especially our formerly incarcerated community health workers, for the advocacy based on the research that we've conducted. Currently, and again, this is a picture from our last TCN meeting, we're now working on trying to, again, as Medicaid for the first time will go behind bars and has already started, will start in California in 2024, trying to think about how best to evaluate the success of 1115 waivers. And so this is a current project that we're engaged in right now, where our whole network is trying to think of quality measures that ought to exist to measure their success of the implementation of the 1115 waivers. And so some real challenges here. I think there's often a real challenge for what we know we should be doing in primary care delivery versus the research. We've had, as I mentioned, real tensions that happen with community capacity building while attempting to build and maintain either high quality RCT or observational cohort studies. And particularly, I think a challenge for me as a researcher is really trying to think of how it is that we engage people with different expertise in the analysis of quantitative studies that use quantitative data, or, and so how it is that we can use more informatics tools to engage them. And then lastly, and I'm happy to talk about this later, is that this does take time and resources, and many funding mechanisms don't really account for the time and resources it takes to kind of employ a CBPR approach. So I'm going to pivot to another example and talk about a different project, True Haven. And before I'll start discussing this, I thought I'd give some background for those of you who don't know us about the SEICHE Center for Health and Justice. In 2020, we kicked off the center, which is a partnership between the law school at Yale and the medical school, really focused explicitly on ending mass incarceration through the domains of the direct provision of care. That's what undergirds all our work, and how that patient care and the questions that emerge from our patients and the practice of care can then inform research, the educational initiatives we do, and the legal scholarship and advocacy. And we benefit from being partnered with Yale Law School with the Justice Collaboratory. I understand that Tracy Mears was here talking to y'all, the Solomon Center, and then the Lyman Center at the law school. Our name derives from a SEICHE wave, and it's a wave that can emerge in stagnant water as a result of interference between two waves traveling in opposite directions, disrupting the status quo. And so members of our team came up with this, really thinking about this way being kind of the clash of the healthcare system and the criminal justice system, and how it is that we can use the health system to dismantle mass incarceration. And at the core of this center are Yale faculty, students, and staff who have been personally impacted by mass incarceration, working across these different domains of clinical care, research, education, and legal scholarship and advocacy. And so, you know, it's working alongside these individuals. So this is an old picture that has transformed the research and the scientific norms, and even how we practice research at Yale. I've found that it flips the questions that you're asking, you know, basic things like, instead of asking what's wrong with these patients, you know, what puts them at risk, we're asking about, why are individuals thriving in these circumstances? What assets exist in communities? And so it's the proximity that we have kind of in the structuring of our center that I think pushes us to ask different sorts of questions. And so in the center's founding, actually in years that preceded this, we really tried to pick off kind of the highest causes of morbidity and mortality in this population. And so we have studies that are focused on overdose, heart disease, cancer, COVID, as Bruce mentioned. What I'll spend the rest of my time talking about is this almost 15-year-long project focused on gun violence. And so this is a project that actually is now in its second round of R01 funding. Yeah, almost in 2013, so yeah, 10 years ago, New Haven, like a lot of cities in the United States, was beset with community gun violence. Again, the rates went up, then came down, and now are back on the rise again. And community partners approached us wanting to have a different approach to gun violence that wasn't led by the police in our city. It's led by the police and the government. And really wanted to think about solutions that could derive and emerge from community themselves. And at the core of this project was finding, as I mentioned, even for transitions, a broad stakeholder group. And so we convened, and this is an older picture. At first, our community group started with 60 folks. Again, community residents, leaders, also city leaders, community organization leaders. And we intentionally tried to create a diverse group with often, you know, from the get, different opinions about who ought to lead, how it ought to lead, gun owners, non-gun owners, et cetera, to get the most diverse group talking about the solutions that we might, that solutions that might be informed better by research. And the group was really committed to using local data to understand what exposure to violence was in our community. And they were explicitly interested in, again, this asset-based approach. And interestingly, you know, one of our first studies was just trying to capture the exposure to violence in communities with high rates of incarceration. It wasn't particularly novel. They were really interested in kind of the early work done in Chicago by Sampson and others, looking at collective efficacy and social cohesion as it relates to exposure to violence. And so we conducted a community-based survey and share with you here, not surprisingly, you know, exposure to violence was incredibly high in New Haven in these specific communities. About a third of community residents had seen or been present when someone was shot. And then also our community researchers designed some of their own questions. They were convinced that, you know, there were many in our group that thought, well, there's no one preparing for this. You can't prepare for gun violence. And in fact, because of their expertise, because of their experience living in New Haven, they're like, no, a lot of community members are preparing for gun violence. And here's just a smattering of the questions. Again, I would never have thought to ask if people have burial insurance, but they said many people buy burial insurance, even for their kids, given the high rates of gun violence. And so this was a surprise finding for us that almost a third of families had bought burial insurance for their kids, given the rates of gun violence. And so the notion of community preparedness feels off to me for gun violence. In fact, it exists, and many people talk actively about it. We trained 55 community members in total in this project to kind of scour the community and ask these questions. And I think that this was an important part of our project. And then, not surprisingly, ended up publishing this and found that social cohesion and collective efficacy were associated with decreased exposure to violence, even after controlling for an assortment of possible confounders for this. And not a surprise finding here, but again, a question that emerged from the community, that started in the community. And we were invited to the first convening at the National Academies of Science just to talk about this small study. And again, our community partners were the ones that presented this work. And when it came time, we wanted to apply for the first R01, wanted it to be partnered where we would be a sharing of resources. There is in kind of the best aspiration of community-based participatory research, there's participatory budgeting. But in fact, found in our community, there was no community organization that was prepared at this point to take on the budget, to take on the administrative and financial responsibilities needed to actually co-partner, co-lead an R01. And so we got our first R01. I was the PI of this, and again, wanted to use local data to tell a new story. And so partnered, I think Andy Papachristos has been on your series before too, with Andy Papachristos to do a social network analysis and spatial network analysis. And instead, what we wanted to do with these data was find individuals and places where by mathematical modeling, the probability of that person being shot or the probability of gunshots in that location was high, but they've actually never been shot. They've never been involved in gun violence. There's never been a shot fired in these blocks. So to find positive deviance, and then again, our community researchers would then interview them and with qualitative interviews and ask, again, these individuals or these areas, how have you been so successful avoiding it? By all probabilities, this block should have been, is there something that you're doing unique in this area? Is there something that you and your family is doing that has prevented you from being engaged in gun violence? And again, from these qualitative interviews, and I won't spend time reading this, but home ownership and having roots in the community was a strong theme in a lot of the interviews, as was access and uptake of behavioral health programs. So again, accessing mental health, trauma resources in the community. At the same time, we used created a causal loop diagram, again, done in partnership with community partners. And I won't spend too much time here, but just to say that when we modeled in this participatory process of creating a causal loop diagram for the number of people affected by gun violence, again, social cohesion came up, mental health came up, and then poverty also came up as three key factors that were tied into gun violence. So really trying to triangulate what was happening in the participatory group model building and also the work that was coming from our qualitative interviews. And then in that R01 also built in to the finances the building capacity of community organizations to lead community engaged research. UNC, a mentor of mine within the social medicine department, Dr. Giselle Corby-Smith, has been one of the real leaders in CBPR. And we brought her team, brought together our community partnered organizations, brought together Yale's business office to say, what are the resources, what are the skills that your community organization needs to have to be able to be partnered in CBPR? And so this was some of the capacity building that we did within this R01 so that in future grant applications, community partners could be equally at the table to get the resources to conduct the research because they're co-leading the work as is. For round two, we were successful in getting a second round, and this time we're testing an intervention. And I just wanted to say, it's like now we are partnering with the Urban League of Southern Connecticut, a civil rights organization led by Miss Virginia Spell. She's a multi-PI. And a real benefit of this is that once a community organization has been a multi-PI, they can then apply and renegotiate their federal indirect rates. So I know Columbia's is high, Yale's is also very high, bordering 70%, and that's not what the Urban League of Southern Connecticut's indirect rates are. And so again, there's that 13%. And so again, in trying to think about how it is that you can reshift power through research, this is what I thought was a potential pathway for doing so. Right now we have this R1. It's a multi-level intervention building on the last one, where again, based on the work that we're doing, we're providing home loans or rental assistance to families whose loved ones are incarcerated, coupled with comprehensive financial education at the person or family level. At the community level, we're training a trusted network of community members, survivors, faith leaders, educators to recognize those that are affected by trauma and gun violence. And at the city and state level, we've convened all those that so, the university, the hospital, banks, local philanthropy, to think about what are the real kind of structural barriers that prevent folks whose loved ones are incarcerated from getting stable housing, access to mental health, to try to identify, again, root barriers for obtaining kind of necessary services. And so that work is ongoing right now. It's a cluster trial, 6 neighborhoods where we are evaluating kind of the incremental delivery of these interventions neighborhood by neighborhood. And some current challenges that we have faced is that because of the funding process through NIH and then through how these large organizations like Yale deliver subcontracts, community organizations don't have at-risks. There's been lots of difficulties executing the budgets. It's actually quite hard to renegotiate the indirect rates, and it's difficult to align data collection. And this wasn't a surprise, but it's become an increasing surprise as our community organization takes on equal responsibility in the execution of the grant. What has happened, though, through this 15-year process, and even with the SEICHE Center, is that we've been able to work on Yale's hiring policies. We've done this in collaboration with the Justice Collaboratory, really now focused on, as I mentioned before, the SEICHE really has the majority of people that are working here are directly impacted by mass incarceration, and that's really forced each time we hire to it's pushed up against the institutional policies for hiring people with criminal records. And so, in the 15 years of doing this, I've realized that Yale didn't have a very transparent or fair policy of hiring people with criminal records to work in the institution. And it'll be announced shortly, but for the first time, Yale will have a policy, and it'll be one that is hopefully far more equitable and reflects the evidence around who ought to be hired, when people ought to be hired with criminal records, and reflects their expertise, how much they do contribute to the science in our health system. The second thing we've been able to do, again, these grants aren't always easy to run. These are complicated trials, but Deanna Hoskins, who is an MPI on a different grant that we have, was just made affiliated faculty. She's she's the first actually with a criminal record that's gone through the process, and you would think that it wouldn't be that hard, but actually it has been. She also is the first without a terminal degree, and in doing so, creates spaces for our students, our learners, to interact with different sorts of faculty, as well as now new opportunities it's opening up for us to partner with her on creating programs within medical school, but also within the School of Management, and training formerly incarcerated leaders to run community organizations. And so I'll end with some kind of concluding thoughts, and then could take, we only have 4 minutes. So CBPR, I think, is an approach that keeps your science honest and urgent. It shifts the power, and thus is the way that leads to sustained change. In my experience, it's been useful to challenging hierarchies in healthcare and universities, both through evidence, but also through relationships. It's in partnership with people for 15 years that I've grown as a researcher, as a scientist, as a primary care provider, but then also have created relationships. Jerry's a great example through human resources and, Yale's general counsel, that in meeting him, it's that relationship over time that shifted the policies. And in that way, it's, of course, it's an approach that I don't use in all the research projects that I have, but it's been a place of personal source and growth. Personal source of growth and joy. And, where I'm going to end is this letter that I got during COVID from behind bars. We've been trying to create more opportunities to engage with incarcerated people in our educational work and in our research. And Bruce is part of a project that we have ongoing now in the Pennsylvania Department of Corrections. And it's a letter of kind of that, for me, exhibits the real talent and the ideas that we have locked up. This guy wrote that, they were unable to participate in COVID trials during the pandemic. And he's talking about, look, another suggestion I have would follow my questionnaire idea. And he talks about this whole survey that he would be to set up a pilot program of MA volunteers who would either participate in ongoing clinical trials for COVID-19 virus or human challenge trials. And he goes on to describe kind of the study that he would want to design. And to me, this is an approach that fully articulates the personhood, the experience, the expertise of people that have been incarcerated. I think it can be used to both unroot existing power structures, but also create new opportunities for science. And so some of my work really right now is trying to think about how could we do this, really try CBPR within prisons. And we're doing it, and it's a real slog, I would say. Bruce, you'd probably agree, with our current trial, Advance, that's being led by Lisa Puglisi, Saad Omer, and Deanna Hoskins. But it's the place, I think, for me, would be a place of growth, a place of opportunity, and a place of caution, like just starting to do research within carceral systems, of course, opens up other cans of worms, especially thinking of our collective history. So I'll stop here. Sorry for the rocky start, and look forward to questions.
Thanks so much, Emily. That was really fantastic. And I think given that we are running short of time, let me ask a question, and I'll also channel a question that we got from the Q&A, and I'll hand it back to you for the final word. So one, I have a million questions. I love this presentation so much, but let me start with the broadest one. So for you as a physician, someone doing very significant clinical work, why research? What can research contribute that clinical practice cannot? And so that's sort of my largest question. And then we got what may be a related question on the Q&A, and the person writes, it seems as though there's recognition of the need to invest more in the healthcare of people who are incarcerated or system involved. How can we make the case for this when it's politically unpopular, when there's little political support, and when the people who we most care about are often dishonored and vilified in public conversations? And I wonder if there's some connection there between the research question and the political context of all of this.
Yeah, so there's lots to say about this. I think the first start is like, if you think about kind of the most basic, like transitions clinic, primary care, I thought it'd be real easy, right? Like it's a duh. You're incarcerated, you have healthcare, you come back, you do not. We like obsess over transitions of care in the community. This is a lot of what we focus on because we know that this is a place of error. People get sick, they die. Like if you're in the community hospital for 24 hours, we get a note, we call your primary care provider. I have residents right now doing this, getting the meds discharged. And we have kind of created two systems of healthcare, totally siloed, never talk to each other. It's like a fourth tier of healthcare system for those that are incarcerated, the worst. And then they come home. And so the question of like, it seems obvious, like, of course we should be providing transitions of care, right? And I think that the thing for me that's not clear, and again in practice, and I'd say is like, what seems like a no duh is not always a no duh. Like who ought to be delivering the care actually does matter. And increasingly with these 1115 waivers, again, first time that Medicaid billing is going to go behind bars. It'll cover 30 up to 90 days prior to release, right? So that you can start billing for Medicaid and transition a person home. A lot of, if we didn't have the research on transitions that said that it should be a community health worker with a history of incarceration that should be embedded, then our own history, our own inertia would say, well, it's a care coordinator. It's any old person. It's a college person. And so research actually does, I think, especially in my opinion, is a tool to really kind of push back on normative practices in medicine, and especially when you're using kind of the highest quality of evidence. It's a randomized controlled trial, like we tossed a coin and said what you were getting. Then it's only then that Medicaid now is saying, and Transitions Clinic Network with a community health worker with lived experience is a model. Otherwise, I think the default answer would be like, well, transition care, and it'll be like any other in any other transition of care. And in fact, there are other studies that have looked at transitions of care based in parole, based in probation, et cetera, and have found either null effects or negative effects in that transition. And so I guess that's the thing, is that to me, that's the place that I do think is important. We know it to be true. People ought to have healthcare. I personally think it's a universal right, right? That's a basic human right. But how it's delivered and who is delivering it are fundamentally, important questions, because that changes the nature of how that care is experienced. And to me, if you were just creating a policy without that evidence, our history would say, that it would just be, a nurse care coordinator in a college student. Like there's lots of programs, like everyone can be a community health worker. And I can't tell you the number of people that approach our, executive leadership, Share Shavit, often saying like, we're doing that already. We have a community health worker. But when you're like, well, it's too hard to hire people with carceral, criminal histories to work within the health system, that's literally the crux of the model. And so it is the research that's important, that shows the evidence. And it also is like, hey, what if we were wrong? What if you don't need that? I'm deeply open to that, that it is really hard to change these practices and policies. So if you didn't need a person with a history of incarceration to be working in the health system so intimately, that would have been a lot easier to do. And in fact, that's not what the research shows. And then I think for the politics, I think that that's also one of the reasons why we really try to, as insofar as possible, use kind of rigorous experimental design in this, because it's such a marginalized population. Oftentimes people think that they either no one wants to do anything, right? So you have to bring some evidence that says this is the highest quality evidence, and we're telling you this is what we see and this is what needs to happen. And also, because it's that, like the general policy decision would be like, again, no one wants to do anything. And so what we've really tried to do is anchor conversations on cost. I think that cost or savings to the state, again, that's a hard decision across our network. You can see, people don't want to talk about quality metrics, but in fact, that's how Medicaid is financing is tied, is like you have to provide a certain level of quality of care so that the carceral facilities, the community health facilities will be able to bill Medicaid. And so I think some of what we've tried to do as a network is really thinking about if our goal collectively is to sustain this and to kind of create transformation in our health systems led by people with histories of incarceration, then these are the metrics that right now the health system is anchored on, and that's the road that we're going down.
Yeah, it's interesting, isn't it? The cost recidivism you mentioned earlier. There's a divergence between the metrics that have traction and the metrics that our values might lead us to. Emily, I wish we had another 2 hours, honestly, for this conversation. Thank you so much for this brilliant presentation. We're very, very grateful. We will be meeting again on April 8th with Andy Papachristos. That'll be a hybrid meeting. And we look forward to continuing the conversation then. Please join me in thanking Emily Wang. Thanks so much, Emily.
Thanks. Thank you, guys. Really appreciate the opportunity.
Bye-bye.